Hello, everyone. My name is Shaleen Sulway. I won't read my entire bio, but I am an advanced practice physiotherapist with 23 years of experience. I provide medical assessments for patients with dizziness at the Enhanced Dizzy Assessment Clinic and the Hertz Multidisciplinary Neurotology Clinic at the University Health Network, Toronto General Hospital. And I co-direct Vestibular Health, which is a vestibular physiotherapy clinic specializing in vertigo, dizziness, balance disorders, and I'm a specialist in facial nerve palsy as well. And then I'll pass it over to Elizabeth.
Hi, everyone. So my name's Elizabeth Crawford. I'm also an advanced practice physiotherapist with a focus on vestibular rehabilitation. My clinical background is actually seeing people with complex neurologic injuries and complex traumatic injury. I am also part of the Hertz Multidisciplinary Neurotology Clinic at the University Health Network, Toronto General. I also provide assessments in our Enhanced Dizzy Assessment Clinic there and co-direct with Shaleen our vestibular rehab program, Vestibular Health. So I am going to start us off today. So Shaleen is just going to put up some slides for us. In our session today, really we would like to help you understand symptoms of dizziness after concussion, and
Hi,
particularly
Elizabeth.
how these, oh, hi, Dr. Tatter. We're just getting started here.
Oh, terrific. I got kicked out, but
Oh,
please continue.
okay. So our goal today is really to help you understand how dizziness, vertigo, and imbalance could be related to difficulties with your vestibular system. So we'll talk about what the vestibular system is, what it does for us, how that can be affected by a concussion. We'll also talk specifically a bit about vestibular rehab and how that might help support your recovery if you are dealing with these sorts of symptoms after a concussion. So dizziness is actually the second most common symptom after concussion. It's second only to headache. It is quite common and can be quite disabling. And depending on the research study that you look at, symptoms of dizziness and vertigo occur in up to 80% of concussions. Now, dizziness at the time of initial injury is associated with a more prolonged recovery. So it is really an important symptom for us to recognize and to evaluate. Dizziness is a symptom and it is non-specific, right? Dizziness is a word that means many different things to different people. And what Shaleen and I usually ask our patients in our initial evaluation is if you couldn't use the word to describe what you're feeling, you couldn't use the word dizzy, how would you say that you feel? And we have heard it all. Dizziness really can be a lot of variable sensations, feelings of lightheadedness, imbalance, feelings of motion, floating, spinning, feeling disconnected or disoriented. Now, vertigo, on the other hand, is a very specific type of dizziness. It's a specific sensation, but still vertigo is a symptom. It's not a diagnosis. Vertigo is the illusion that you're moving, even though you know you're not, or an illusion that the environment is moving when you know it's not. It often has a rotational or spinning sort of component, a spinning sensation, seeing your environment turning. But vertigo can also be a feeling of tilting, bobbing, rocking, dropping, or feeling like you're being pushed or pulled. One of the most important things we do when someone comes in for an evaluation about dizziness is to take a good history. So our initial assessment sessions are about 90 minutes long, and sometimes we spend more than half of that appointment time to really try and understand what your symptoms are like. And your symptoms can help us narrow down what a diagnosis is. It tells us a lot about what might be the problem. So the first step we take when taking a history or understanding what your dizziness is like is to understand how you describe the symptoms, really understanding what the dizziness feels like to you. We also want to determine if there is true vertigo. Our second step is to identify the timing of your symptoms. So when you experience dizziness, how long do the symptoms last? Are you dizzy for seconds, minutes, or hours at a time, or are you just constantly feeling this way? Our third step is to understand any triggers for your symptoms. So does your dizziness happen related, for example, to certain movements or position changes, certain movements of your head, or does it happen in certain environments? Is your dizziness worsened with visual stimulation, like scrolling on a screen or seeing things moving around you? Or alternatively, do your symptoms just come on spontaneously with no particular trigger? So the description of your symptoms, the timing, and the triggers can really give us a lot of clues as to what might be causing your dizziness. We also want to know if there are any symptoms associated with the dizziness, as this again can give us some more clues as to what might be happening. We usually ask about hearing changes, so loss of hearing or fluctuation in your hearing, ringing, humming, buzzing sounds in your ears, pressure or fullness in your ears, also headache, nausea, vision changes, right? These features, these symptoms that come along with the dizziness can again help us identify potential causes. Now, imbalance is also a symptom that we ask about in detail. Some people describe dizziness and they really are feeling a sense of unsteadiness, disequilibrium, feeling off balance. And this feeling of being off balance can sometimes be associated with a sense of being disoriented in space, spatial disorientation. And some people do describe feeling like they're tipsy or drunk. And some people actually do lose their balance or experience falls. We again take a systematic approach to understanding your symptoms of imbalance, and we're particularly interested in if there's anything that makes your imbalance worse. For example, are you okay when you're sitting still and off balance when you're walking, or is your imbalance worse when you're moving your head? Do you feel off balance on uneven surfaces or in dark environments? Do busy places like grocery stores, big box stores, malls affect your balance? So again, understanding the timing and triggers for any imbalance or unsteadiness can help us get a better idea of what might be causing your problem even before we do a physical assessment. So we will talk a bit about what the physical evaluation involves, but let's first cover some of the causes of dizziness, vertigo, and imbalance after a concussion. Now, dizziness in general can have many different underlying causes. Examples might be blood pressure or heart rate changes, low blood sugar, low iron, anxiety and panic, medication side effects. But today we're going to focus on the inner ear and brain, our vestibular system. So our vestibular system has two parts. One is the inner ear. This is known as the peripheral vestibular system. And the second part is our brain, and that is known as the central vestibular system. So the central vestibular system involves the parts of the brain that process vestibular signals, so the signals coming in from the inner ear, and also other sensory signals that are related to balance. So dizziness can originate with problems in the peripheral vestibular system, the inner ear, the central vestibular system, the brain, or can be related to a combination of the two. Let's look at the inner ear a bit more closely. So the part of the ear that we can see is the outer ear. The middle ear is the space and structures that are behind our eardrum. And the inner ear is deep inside our skull, and it's completely surrounded by the temporal bone. Now, the structures of our inner ear are delicate, and they can get jostled or injured with the forces to the head and neck that can cause concussion. And that can happen even without a direct impact to the ear itself. So the function of the vestibular part of our inner ear is actually to sense head movement. In each ear, we have 3 semicircular canals, and this part of the ear senses rotational or angular acceleration. So for example, turning your head side to side or tipping your head up and down. We also have two otolithic organs, and these are called the utricle and the saccule. And this part of the inner ear senses linear acceleration and gravity. So forwards and backwards, side to side movement, and vertical movement up and down. The vestibular system also includes the vestibulocochlear nerve. This is the 8th cranial nerve. So this is the nerve that sends signals from the inner ear balance sensors and also the hearing structures into the brain. The central vestibular system are the parts of the brain that process the information coming in, and this particularly is relayed through our brainstem and our cerebellum. So information about head movement travels from our inner ear along the nerve to the brain. And if all the input signals coming into the brain are normal, and if the brain is processing these signals properly, then we have output signals that are sent to our body through different reflexes. So one really important reflex is called the vestibulo-ocular reflex. So this goes to our eye muscles. And this is the reflex that allows us to see the world clearly while our head is moving. So a second reflex is called the vestibulospinal reflex, and this reflex sends signals to our postural muscles. This is what allows us to stay upright and balanced. So primary functions of our vestibular system, one is to keep our vision stable, right? It's our internal Steadicam, our internal image stabilizer. And this is happening through the vestibulo-ocular reflex. And then the other primary function is to keep us upright and balanced. Again, this is through the vestibulospinal reflex. Our inner ear and brain, our vestibular system together, also help keep us oriented in space and keep us from feeling dizzy. A concussion can result in abnormal functioning of any part of the vestibular system. So an injury to the inner ear balance organs or the nerve can result in abnormal signals being sent to the brain. And a concussion can also change how our brain processes information about balance. So if vestibular signals are not accurate or asymmetric, or if this information is processed inaccurately, then the output is going to be inaccurate. And this causes symptoms of dizziness, vertigo, and imbalance. It can also cause visual symptoms related to disruption of that internal Steadicam, a change in the function of the vestibulo-ocular reflex. So the inner ear disorders that are listed here are all possible causes of dizziness after a head injury, but thankfully most of them are relatively rare overall. BPPV, benign paroxysmal positional vertigo, is the most common cause of vertigo in general and also after head injury. The second most common condition that we see as a cause of dizziness after a concussion or imbalance after a concussion is actually related to sensory mismatch. So visual vestibular mismatch is another term you might hear to describe this. So now I'll pass it over to Shaleen to talk more about these two common vestibular causes of dizziness.
All right, thank you, Elizabeth. So we'll start with one of the most common causes of vertigo, benign paroxysmal positional vertigo. We use the acronym BPPV. This is the most common presentation of vertigo in adults anywhere in the world, either with or without head injury. But under the age of 50, the most common cause is a head injury. So this is the kind of vertigo that often first occurs in bed. You lie down or you roll over and there is violent or very strong spinning. It doesn't last long, usually 10 to 15 seconds, but in some cases can last up to a minute, but then it stops. However, it can be recurrent, so it can occur multiple times. And this vertigo often is triggered with certain positional changes. And the classic ones are lying down, especially if you lie flat, rolling, bending over, or looking up. It generally will not occur if you're sitting still or if your head is still, you're walking, you wouldn't feel it. So, but even though you may not be spinning, you still may not feel great in those upright positions. And there's often associated nausea, vomiting, and imbalance, and these symptoms can sometimes linger. And the good news is that this does respond very well to treatment, especially if we can diagnose it properly. So we'll look at what BPPV is. We'll start with the anatomy of the inner ear. So we have the utricle, which is one of our gravity receptors inside the ear. And inside this utricle, we have small hair cells, and on top of the hair cells are very tiny calcium carbonate crystals. And they sit on the hair cells to allow the crystals to bend, which then allows us to figure out which way we've moved in space. Now, these are a normal part of the anatomy, but when you have a concussion, what can happen is that these crystals can get dislodged and migrate into any of the three semicircular canals that you see here. All of these canals have openings into the utricle. The most common canal to be affected is this posterior canal in the back. It is the most gravity dependent. So once crystals fall out of the utricle and enter the posterior canal, if you don't move, nothing happens. But if you move the head in a certain way, the crystals will move. This will then stimulate your ear to send false signals to the brain, which then triggers our vestibular ocular reflex, causing vertigo, and our vestibular spinal reflex, which causes the imbalance. And BPPV is something that can occur immediately after a concussion. Sometimes it can be a few days, or sometimes even up to 3 to 4 weeks after the initial head injury. So to test for this condition, what we use is a technique called the Dix-Hallpike. So we start by turning the head 45 degrees to the side that we're testing, and then we quickly lower your head back so that it's 30 degrees below the horizontal. And then we look to see whether crystals are moving in any of the three canals. So the three canals, we've color-coded them differently. We've got the blue canal, which is the horizontal canal, the green, which is the superior, and the red, which is the posterior. And every canal will connect to different eye muscles. So if crystals moved in the blue canal, we would see a horizontal beating eye movement. If they moved in the red canal, we would see a upward and clockwise or counterclockwise torsion. So this helps us figure out, based on the eye movement, where these crystals might be situated. So when we do this test, we ideally want the person's eyes in the dark. So we use infrared cameras so that we can capture the eye movements. Your brain can actually suppress some of the nystagmus or the eye movements if in light. So this is why we put patients in the dark. And then we look at the direction and the duration of the eye movement to help us figure out where these canals are floating. So I'll show you the video here. So I am doing a right-sided Dix-Hallpike on this patient. And then once I lie him down, we watch the eyes and look at the direction of the eye movement. So right there, we see an upbeating counterclockwise torsion, and that immediately can direct me to the right-sided posterior canal. Once we figure out where the crystals are, we can do a treatment. Each canal has its own treatment. In the video we saw, the crystals were in the posterior canal, so we would do something called the Epley maneuver. So we start to move the head through these 6 different positions. We keep each position, we hold each position for a minute, and by the time the maneuver is over, we hope that the crystals are back into the utricle where they belong, and the vertigo should feel a lot better. If we don't see any dizziness with the Dix-Hallpike, there's another test that we do. This is the supine roll test. This tests the horizontal canal. So you can see when I lie this patient on her left side, we see a different nystagmus. It's a left beating nystagmus. In the horizontal canal, it's a little tricky because it doesn't matter what side you lie on, you'll see nystagmus. So you'll see me in just a second roll her on her right side. And then we look at what side is stronger and how long the duration of that nystagmus is to help figure out where these crystals are. You can see it's fairly short-lived. So just like we have the Epley maneuver for the posterior canal, we have a very specific treatment. It's called the barbecue roll that we do for this canal as well. So we do have very strong evidence in the research to show that the assessments and treatments for BPPV are very effective. In fact, we have an 80 to 90% success rate with fixing BPPV with just 1 to 3 treatments. And for any clinicians in the audience, there is a clinical practice guideline that offers very explicit recommendations on how to assess and treat BPPV. Now, while we have excellent abilities to treat this condition, it can be more challenging after a concussion. Often we do require multiple treatments compared to someone that's developed this problem without a head injury. It can be in both ears. It is 3 times more likely to involve multiple canals in the inner ear, and it can reoccur a little bit more frequently. So we do like to stay on top of this condition, but generally speaking, it's managed fairly well. So we'll move on to the other most common cause of dizziness that we see in the clinic. And I like to think of this as a sensory mismatch in the brain. So to understand this concept, we'll step back and look at the physiology again. So we talked about the back of the back of the brain receiving information from the inner ear about balance, but the same part of the brain is also receiving information from the eyes and from our proprioceptive system, which is basically your ability to feel where you are in space. So this is information that often comes from the soles of your feet and from your neck as well. So in order for your brain to give you good balance and to prevent you from being dizzy, you have to pay attention to information coming from all 3 areas. And if any of these 3 areas are sending inaccurate information, or if these 3 areas are not sending the same message, then the brain will interpret that as dizziness or even imbalance or motion sickness. And often this can happen to some of us even without a concussion. If you think about it, if you're sitting in a car in the back seat and you're looking at your phone, in this case, your eyes are looking at the phone and they say, we're not moving. It's because they're not looking at the road. Our ears are sensing the motion of the car, and our feet and our body and neck are saying we're not moving. And this creates a mismatch, which can lead to motion sickness even without a concussion. And when we look at past studies on patients with concussions, this is even going back to the 1990s, we've seen that patients after a concussion tend to rely more on visual cues for balance. And you can see that by having someone close their eyes. They have a harder time balancing. And one of our theories in the vestibular world is that we think this is an adaptation. So if you have an inner ear injury, the inner ear may be sending faulty messages, and your brain may choose to ignore the inner ear signals. And instead, it can start to over-rely on the eyes a bit more for balance. And this is fine in the short term as a strategy, but it's not a great long-term strategy. So if we don't correct this problem early on, this can lead to a condition that we see very commonly in our clinic called persistent postural perceptual dizziness, another acronym called PPPD. So patients tend to complain of feeling constantly dizzy. It's usually not true spinning, but rather a floating, swaying, rocking, or unsteady feeling. It is present on most days and worse when you're upright, worse when you move yourself or if someone moves you, or when there is exposure to complex visual patterns or things moving in your vision. So patients will often say they feel much worse in large or narrow spaces. Screens make them worse. When they're scrolling, they feel worse. They're worse in grocery stores, crowds, malls, or even moving vehicles. So one of the tests that we do for our patients with this type of persistent dizziness, or really any type of dizziness, is balance testing. And I find this particular test tells us a lot. So with this test, we can manipulate your balance inputs to figure out whether you're overusing vision or maybe not relying on the vestibular inputs. So we have 4 parts to this test, this posturography test that we do. The first one, we have you stand with your feet together on a solid surface with your eyes open. So the idea there is you're using all 3 senses for balance. You're using your vision, your vestibular system, and your proprioceptive system. And then one by one, we start to manipulate the senses. So in the second test, we have you close your eyes. So now we've removed vision, but your ears and your proprioception is providing that balance. In the third test, we have you stand on an unstable surface. So now you can't feel your feet as well. So we've altered the proprioception, but you use your eyes and ears to balance. And then finally, in the last test, we have you close your eyes on the unstable surface. So now we are primarily biasing that inner ear to help you balance. And then we can further create challenge by moving the head on the body in each of these test conditions. So if you have an inner ear problem, let's say in your right ear, you may turn your head to the left and you're steady, but if you turn your head to the right, you tend to fall over. So I hope this makes sense. So you have three senses for balance: your vision, your vestibular, your proprioception, and we are able to I test all three senses with this balance test. Now we have excellent technology in our clinic that allows us to track sway patterns in each of these four balance tests. And this is an example of a fairly normal result with one of our patients. So here, the first test, they're standing eyes open on a firm surface. We're testing all three senses. We then have them close their eyes. We're removing vision. We then put them on an unstable surface and remove proprioception. And then finally, we have them close their eyes on the unstable surface, and we're testing that vestibular system. So what we're doing with what we're looking at is the sway patterns. And in this example, all the sway patterns are fairly equal. If I take you to this one, this is a person that has vestibular weakness. So they do fine in the first three tests, but when we have them close their eyes on an unstable surface, they have a really hard time balancing. The sway patterns are quite widespread. Here's an example of someone that has a lot of visual dependency. So in this test condition on the left-hand side where the eyes are open, the patient has no problems balancing. Whereas on the right-hand side, where vision is removed, the sway patterns are particularly large. And these are the patients that seem to tell us that they have difficulty with screens, with scrolling, busy environments, or any kind of visual stimulation. And the thought is that they're overusing vision to balance. And because of that, they're struggling to process the world around them, especially if it's visually complex. And then in this last example, I'm going to show you all four tests seem to have high amounts of sway. So in this person, it's not necessarily a vision, vestibular, or proprioception issue. It's rather the brain being very sensitive to the signals coming in. So depending on what we find with this balance testing, we can figure out what system is not working or which one is overworking, and we can start to correct that. And once this is achieved, a lot of our patients will say they're no longer feeling dizzy. So what does vestibular therapy involve? We usually start with a very comprehensive assessment. It usually takes us about 90 minutes to go through a full assessment. We do clinical tests of the inner ear and central vestibular function. Now, because of limited time, we weren't able to show you all those tests today. And then we do some balance testing with posturography and walking tests. And the goal is to establish a diagnosis, because if we have a diagnosis, we can effectively treat that. Treatment is guided by the assessment and is always individualized. We want to train your brain to recalibrate how it's interpreting vestibular signals, and this can only occur through movement. So our approach is a very active and exercise-based approach with a big focus on a home exercise program. And I see it's 6:30, but I'm almost done, so I'll just finish up here. One exercise that is recommended for all patients with dizziness is walking. And if you've listened to previous Canadian Concussion Center talks or you've heard Dr. Tatter speak, you will have heard the importance of this. And we recommend 20 to 30 minutes of brisk walking every day. And it is okay to have a little bit of dizziness if it increases slightly. Usually Elizabeth and I will say, try not to let the dizziness increase by more than 3 points from your baseline. And if you do have it increase by 3 points, just take a break, let it settle down, and then proceed again. Gone are the days where we used to cocoon patients and tell them to be in a dark room until they're better. We now know that early physical activity can really promote recovery. And walking really allows your brain to compare vision, vestibular, and proprioceptive inputs. And if there's discrepancies, then your brain can start to work it out and learn how to recalibrate. But this recalibration will not occur without movement. We do other exercises as well. If there's BPPV, we'll do maneuvers, balance exercises, specific walking exercises. If the vestibular reflexes are affected, we can train the vestibular ocular reflex. And then if the brain is sensitive to movement, we can use habituation strategies. Now, one thing I really like to drive home is recovery is not a linear process with our patients. You can have fluctuations. You can have a good day and not have a great day the next day. But the trend should be that you are getting better. And this fluctuation can occur because of fatigue, illness, lack of sleep, stress. Your brain is working really hard to keep you from feeling dizzy and falling over. And if that brain is stressed, it will have a harder time. So sometimes patients will even tell us that their thinking, their memory, concentration, multitasking all becomes affected when they're dizzy. And this can happen even without a head injury. We see this in our vestibular patients who've had a virus, for instance, that affects the ear. And it's often because your brain is putting so many resources in trying to sort out the mismatch of signals and not let you fall over that there's not enough resources left to manage the cognitive tasks. Pacing is very, very important. I usually like to show this diagram to my patients. Red is the zone where you have significant symptoms, yellow is mild to moderate, and then the green is 0 to minimal symptoms. For patients that tend to push through dizziness and end up having 8 or 9 out of 10 symptoms, they tend to be very overwhelmed, and it takes a long time to recover back to baseline. So we always say don't avoid this pattern at all costs. The way to deal with dizziness is to allow your dizziness to increase by just a few points, up to 3 or 4 out of 10. And then at that point, you still have control to de-escalate that dizziness. So some of the strategies that we talk about with our patients, when you hit a 3 or 4 out of 10, take a moment, close your eyes. We teach patients grounding strategies, trying to really feel where you are in space. Use those grounding cues to validate where you are in space. Breathing, slow, deep breaths can be very helpful at calming their brain down. Cognitive reframing, remembering that symptoms are temporary and will pass. And distraction techniques. So if you do have dizziness, what do? I would say you can consider an ENT consultation or a multidisciplinary clinic that specializes in dizziness. Consider an assessment with a vestibular rehabilitation physiotherapist. And treatment is best done in a team approach. So at TGH, we have a clinic called the Enhanced Dizzy Assessment Clinic, where you're first assessed by an advanced practice physiotherapist like Elizabeth and myself. We help figure out a diagnosis. We're able to do very thorough assessments, order imaging or lab tests for the inner ear, and come up with a plan. And then we have a team to leverage. We have ENT, neurologists, full inner ear testing facility, psychiatry, nursing, and physiotherapy as well. So just in wrapping up some take-home messages, dizziness is common after a concussion, and it's often accompanied by balance impairments and visual symptoms. The initial presentation of dizziness is an important clinical finding and should be evaluated further with vestibular imbalance testing. I would say if it's not resolving within 2 to 4 weeks, then it should be looked at. BPPV is the most common, responds really well to treatment, and doesn't, regardless of where you are in your dizziness journey, in your concussion journey, I would say dizziness, vertigo, and balance can improve. So speak to your doctor if you have dizziness. Elizabeth and I are always available for short phone consultations to see if vestibular physiotherapy is right for you. So I will wrap it up there and I'm open to any questions.
Thank you very much, Elizabeth and Shaleen. Can everybody hear me?
Yes.
Oh, good. So I'm back in action. Sorry for that interruption. Christian, did we tell people to put their questions in the chat and that we would try to answer as many of them as possible? And Christian, did we run a poll about who the audience is this evening? Because we always like to know that.
You know what? We did not. So if you'd like,
Do
I
that
can run
now?
that poll now.
Okay, please do. So this is just a brief poll so that we can get it right and gear these towards our audience. So please enter who you are. If you're more than one of these, check off both of them. And thank you very much for doing that. The two presentations that you just heard were absolutely superb, and you can really get a feel for how expert these people are. They are known as vestibular therapists or vestibular physiotherapists, and not all people with those credentials have as much knowledge as these two people do. And that's why they're my favorite people to refer patients to who are suffering from imbalance and dizziness after a concussion, which, as you've heard, is the second most common symptom after concussion. So let's try to answer some of the questions. I see that there are almost 100 people on the line today. So let's see the questions, Christian. I don't. Okay. So here's a question from Gabriel. How do you assess for Meniere's disease versus BPPV? So that's a great question, and I'm glad you're not directing it towards me. So Elizabeth or Shaleen, how do you answer that one?
Thank you very much. That's an excellent question. So, Meniere's disease, I'll just describe or define what that is for people in the audience. Meniere's disease is a condition where we usually see four types of symptoms. We have attacks of vertigo, and these attacks of vertigo are spontaneous in nature, so nothing triggers them, they come out of nowhere. They always last minutes to hours at a time. And we see associated oral symptoms. And what I mean by oral symptoms is ringing in the ear, pressure in one of the ears or a sense of fullness, and fluctuation in hearing. So we usually listen for that in the history. And this is where Elizabeth was talking about timing and triggers. So the timing of a Meniere's vertigo spell is minutes to hours, and triggers are it's spontaneous in nature. Whereas BPPV, the triggers for that is position changes. So bending forward, lying down, rolling over, and the duration is seconds. So a lot of times, even before doing any kind of a clinical exam, it's the history that will lead us down the path of this being Meniere's or BPPV. And then there's assessments that allow us to confirm those findings. I hope that made sense.
Terrific. Let's have another question. Can you please please replay one of the links? Well, I think you'll have to wait perhaps until you see this on our website, and probably in 2 or 3 weeks, Christian will have this presentation up on our website. So please go to Canadian Concussion Center, UHN, to look at any of the sessions that we have. We record them all. So here's a question. I lost hearing in my right ear, and then some hearing slowly came back, but still not all. Does this affect dizziness? I still struggle with vestibular symptoms that is so hard to explain to doctors and insurers that I'm still suffering, and that is a very common issue. So do you want to handle that, Shaleen?
Sure, actually, I'll let Elizabeth take that one.
Oh, okay. Elizabeth, can you handle that one?
Sure. So you're right that our inner ear is responsible for hearing as well as balance. And there are some conditions or sometimes you can have after a concussion injury to the inner ear that affects both. I think it's important to get a good evaluation. I can't give sort of individual advice or suggestions without doing a full consultation. You are right, it can be really difficult to describe symptoms. And so when you're seeing healthcare professionals or having an evaluation, really being able to narrow down description of what you're feeling, the timing and the triggers can be really helpful. Now, this idea of being really overstimulated with busy environments, with screens, with visual information, that is sometimes seen when people are over relying on vision. So what Shaleen was talking about of this sensory mismatch, sometimes if you're using too much of vision, not enough proprioceptive or vestibular inputs to help you keep your balance, it can be really, really challenging to cope with those the visual information. If your brain is relying too much on your vision for balance, it's hard to figure out if the thing that you are seeing in your environment moving is what's moving, or if it's you moving relative to your environment. You really need to uptrain using proprioceptive and vestibular cues to help sort that out and hopefully help you feel less symptomatic.
Here's a question. I rarely drive on the highway. I find that if I drive a distance, say for 20 to 30 minutes, I feel anxious when I'm driving. But when I get out of the car, I feel unsteady on my feet. Do you have any thoughts about the cause of all of that and what to do about it? Who would like to answer that, Shaleen or
I can
Elizabeth?
take that one. I can take that one.
Okay.
Again, it's hard for us to figure out exactly what might be causing your symptoms without doing a full evaluation. So I can talk more generally. It's really common to feel dizzy or motion sick while you are in a moving vehicle or sometimes afterwards. And again, this might relate to that idea of sensory mismatch, right? When you're in a car, your eyes, your ears, and your body sense might be giving you different signals about balance and can make you more prone to dizziness. Now, that feeling of sensory mismatch can actually trigger a stress response. So that sometimes can make you feel a little bit more anxious or that fight or flight response kick in. And sometimes just driving itself, especially if you're in big city traffic, can make you feel a bit anxious. And usually if you are in that state of fight or flight, it makes any dizzy symptoms feel worse and can make you feel more unsteady. So I hope that helps. I hope that answers the question.
And here's a question about the syndrome of mal d'embarquer, um, which which the person feels is a sense of getting off a ship months after being on a cruise, for example. Is this related to vestibular problems? And can the predisposition for this be a factor for post-concussion syndrome symptoms such as headaches? So that's a tough series of questions, in
Mhm.
fact.
Thank you for the question, though. So the condition that this person is referring to is called mal de débarquement syndrome. That's another acronym in our list of diagnoses called MDDS. And this is a condition when you're coming off of a boat or a cruise or an airplane can trigger this as well. When you get back on land after having this continuous sense of motion, your brain has a hard time readjusting and getting your land legs back. It's quite normal to have this for a day or two, but it becomes more of a problem or it becomes mal de débarquement when it persists for longer than a couple of days. And this can give you this feeling of constant sense of motion, constant sense of dizziness. We usually find there's a lot of overlap between mal de débarquement and the persistent postural perceptual dizziness that I talked about in the presentation. One of the key differentiating features between MDDS and persistent postural perceptual dizziness is people with mal de débarquement often say they feel better in passive motion. So if you sit in a car and you're in a moving vehicle, you don't feel as dizzy. And we think a lot of mal de débarquement, or if it's the persistent postural perceptual dizziness, is your brain not being able to readapt to those sensory inputs coming in. So more of a sensory mismatch. And I think, Dr. Tatter, can you repeat the last part of that question? It was something about headaches.
Would it bring on headaches ultimately if this persists?
No, so I don't think we've seen that, or I haven't seen any evidence to suggest that.
Thank you very much. So the next question is about beta histine. Do you recommend that to be used? And this particular person did experience severe dizziness when there was a shortage of this medication. Um, so how do you feel about beta histine as a treatment for dizziness?
Absolutely. I'm really glad this question was put forward. So I can answer this not as a physiotherapist, but more as an advanced practice physiotherapist in that capacity, because we do use that medication in the clinic. So beta histine often is overprescribed. If you ask us in the clinic, it is actually a medication that is designed to prevent attacks of Meniere's disease, vertigo. So it prevents the spontaneous attacks of vertigo that go on for minutes to hours, and it's used as a preventative for that. It generally will not help with any other forms of vertigo. And for it to work, if you do have Meniere's disease, it does need to be taken on a regular basis.
Yeah, I would agree. For persisting concussion symptoms, vertigo or imbalance, beta histine is useless.
Absolutely agree with that.
Another attendee has been saying, where do we go for this type of treatment in the Toronto area? Well, I can answer that easily. You can go to the Toronto General Hospital, for example. Now, you do need a referral. And I guess we should also indicate that these services are not generally covered by your health insurance plan. When you come to see me or Dr. Tartaglia, it's free. But with vestibular therapy, it's not free, so you have to expect to receive a bill for service, and that's not a decision that we made. The government of Ontario made that decision about 20 or 30 years ago, and they have stuck by it. So they do not provide these services free, which I think is a mistake, but that's what we're stuck with in this province.
Now,
So
Dr.
let's,
Tatter, I know
sure.
some people will be outside of the Toronto area, or traveling downtown to Toronto General might be a bit of a challenge. So I just wanted to give some people some other resources of where else they could go aside from coming to see us. And you're right, most physiotherapy, outpatient physiotherapy in Ontario is not covered through OHIP. So it would be fee for service regardless of where you go. The Vestibular Disorders Association, VIDA, vestibular.org, does have a healthcare directory, and you may be able to find a physiotherapist or a provider who has a specific interest in vestibular disorders there. So I just wanted to let people know, if they were looking for somebody who has expertise, that would be another resource, if especially you're outside of the Toronto area.
I think it's a very good idea to try to be referred to a center by your MD. In general, and this is not always the case, but wherever you are in the province, hopefully you do have an MD who can help refer you to the appropriate healthcare professional, like a vestibular therapist, to help out, especially with persisting concussion symptoms. We have found that there are people who tend to practice this who aren't as skilled as you would hope, but in general, your family doctor can help steer you correctly. So let's go to another question. When my osteopath who treats me for daily headaches tries to turn my neck or to stretch it, I start to get dizzy. That's a great question. What causes that? So who wants to handle that?
So when I hear that, thank you for the question, by the way. When I hear head movements triggering dizziness, first question, is it a true vertigo type of feeling? Does it feel like the room is spinning? Is it a transient feeling with head movement? The first thing I think of is it could be BPPV. because that is dizziness with change in head position relative to gravity. And that's what turning the head to the side would do.
Excellent answer. I hope that helps. Can you walk on a treadmill, or do you have to walk outside in order to get better?
Excellent question. I would definitely say start by walking outside if you can safely do so. And I'll relate it back to the same sensory mismatch that we talked about. So we have our three senses: vision, vestibular, and proprioception. When we walk outside, our vision sees the world go by. So our vision says we're moving. Our inner ears sense motion. So they are in agreement with us moving. And our feet can feel the world, can feel the pavement and agree that we are moving. So all of our senses are sending the same message. What happens on a treadmill, your ears are sensing motion, your feet are sensing motion, but your eyes say, but we're not moving. We're in a stationary room. So that can trigger sensory mismatches where your eyes are saying something different from your ears and feet, and that can increase the dizziness in some patients. So yeah, my preference always is start outside until the three senses are calibrated and speaking the same language, and then you can transition onto a treadmill.
Yeah, I agree with that. My preference is not for treadmills unless the dizziness is very minimal, because we've actually had people who have fallen off a treadmill because they become a little unsteadier. So be careful with treadmills. I prefer, for example, elliptical trainer, or even swimming. Swimming is a great exercise, but you won't be able to do the crawl if you have a lot of dizziness, because every time you turn your head to take a breath, you're going to get dizzy. But if you do the back stroke or the side stroke, you don't have to turn your head, and you won't get dizzy. So swimming is another excellent exercise to try to get over persisting concussion symptoms. Um, can you please uh, um, show the link again to the recorded videos that will be on our website? So um, I think Christian has done that. So if you look at the chat, you will be able to see the link to the website that has all of the previous recorded sessions, and we'll have this session when it's placed on the website in a few weeks. So here are some new messages. I swam lengths, front crawl, through dizziness. I knew that it was good for me, though I felt dizzy in the moment. Okay, so that does confirm what what we've learned from our patients, that doing the crawl does actually enhance dizziness. A breaststroke is also good. Okay, that's a good suggestion. My experience with the breaststroke is that a lot of people do it like it's a butterfly stroke, and that lunging upwards and downwards, if you turn the breaststroke into like a butterfly stroke, it does not work. So minimal head movement with the breaststroke will be okay, but you need to try it to be sure. Most of the time you're better off with the side stroke or the back stroke.
I would just say one more thing. When it comes to dizziness, like you got to try these things, as Dr. Tatter just said, as long as it's not increasing the dizziness by more than 2 or 3 points, I think you're safe to do that. So just, I usually like to use that as my guide, is don't let symptoms increase more than 2 or 3 points. If they do, take a break, allow it to settle down, or maybe try a different stroke.
So I'm looking for any questions that we haven't. I lost hearing in my right ear, and then some hearing slowly came back, but still not all the hearing. does this affect dizziness? In other words, if you have a hearing loss as well, does that affect whether you're going to be dizzy? Shaleen or Elizabeth?
I can take that one. So I think if you have not had your hearing evaluated, like with a hearing test with an audiologist, that would be a good idea to get an idea of the degree of loss. In some folks who have a head injury that causes a change in the hearing function of the inner ear, there might also be a change in the balance function of the inner ear, but that really has to be determined based on a full evaluation to see is any dizziness you're experiencing because of an inner ear balance issue.
How do we book for consultation? So I think we have outlined that. So do you want to just give it again, Shaleen or Elizabeth? How can they find you?
You can find us through our website, vestibularhealth.ca, and you'll see more information on how to book an appointment there.
So here's another question. How can you communicate that there are objective deficits in the absence of nystagmus? Is there a way to document quantitatively the findings on balance testing? How do you feel about that?
Yes, absolutely. So our assessment, our physical exam, can take up to 45 minutes to do. So we're looking at a number of objective tests, looking at how the eyes move. That's an oculomotor assessment. We can look at the vestibular reflexes, specifically the vestibular ocular reflex. We can test the dynamic visual acuity, which gives us an objective finding. The balance testing, as you saw, I was showing some posturography images that gives us objective findings. Our gait assessments do the same. And then if we want to go one step further and quantify what's happening in the inner ear, we have a lab. It's called the Center for Advanced Hearing Imbalance at Toronto General Hospital, where they do up to 4 hours of inner ear testing. They can look at every part of the inner ear and quantify how each part is functioning. So that's often sometimes if we need that clarification or quantification of what's happening with the balance organs, we can order those tests.
Do you recommend using the VOMS, vestibular ocular motion, I guess, test?
I can field that one. So the VOMS, in case anyone's not familiar with it, is a way of evaluating sensitivity to eye movement and head movement. So it asks you to do a number of different movements, standardized movements in sequence. It asks you what your symptoms are like with those movements and how long it takes for your symptoms to settle to baseline. So it's a way of having your clinician evaluate your status and track if there's any change or improvement in symptoms over time. For example, the symptoms are less intense with that same movement, or the symptoms don't last as long as they did when you first started therapy. So it is a assessment that standardized assessment that many clinics use. But to be honest, I think Shaleen and I don't particularly use that outcome measure because it is often very symptom provoking when you are dizzy. So sometimes using the same sort of principle, having a standard movement that you do and having an idea of what your symptoms are like in terms of intensity and duration can be a way of tracking whether there's change over time. The VOMS can be a useful tool in some people, but generally I find that the folks that we see, it's an evaluation that takes a lot of time to do and often is very symptom provoking. So when we're trying to be really efficient and effective in coming up with our diagnosis and a treatment plan in our first session, it's not usually one of our go-to outcome measures.
And here's another question. Experiencing imbalance after being exposed to noise in the environment. So can noise bring on vestibular symptoms, for example? That's a
Yep,
bit unusual, I think.
yeah, no, there was a long list of possible inner ear conditions that can occur after a concussion that we put up there. They're relatively rare, but there is one condition called superior semicircular canal dehiscence. And one of the findings with that is loud noises can cause dizziness. It comes with several other symptoms as well, and that's something we can test for. We actually have a device that puts loud noise into one of your ears, and we can check to see if there's any abnormal eye movements and
You can't
nystagmus with them.
stump Shaleen. That's fantastic. That's good. Okay. Um, do you recommend any medications for PPPD?
There is no medication that will work well for BPPV. It's a mechanical problem in the inner ear where the crystals have come out of the right location and entered the another part of the inner ear. So it is a condition that responds really, really well to physical maneuvers like the Epley maneuver. And within 1 to 2 Epley maneuvers, we can fix that. The only time maybe a medication could be considered would be an anti-nauseant if you're feeling really nauseous from the dizziness. That could be considered, but no prescription medications for BPPV.
I just want to make sure we're getting our acronyms right because BPPV and PPPD sound very similar. So sometimes they're in our clinic, we'll call it triple PD, just to be sure we're talking about the right condition. So if the question was about the persistent postural perceptual dizziness, there is some evidence that medications like SSRI or SNRI medications can be helpful in improving the persistent dizziness in that disorder.
Is there overlap with excessive tinnitus causing headache, lack of concentration with vestibular issues? Have treatments for dizziness been shown to help tinnitus? So tinnitus is really a tough issue. Often does occur in the same person who has dizziness, but the treatment for dizziness, in my view, will have no effect on tinnitus. But let's hear what the experts say. Elizabeth or Shaleen, how do you feel about any of your treatments in patients who also have tinnitus? Does it help the tinnitus?
I would agree with you, Dr. Tatter. No, our a lot of our treatments, tinnitus comes from the cochlea, which is the hearing part of the inner ear, and dizziness is coming from the balance portion of the inner ear. And the only time where there may be overlap would be in a condition called Meniere's disease, where you can have tinnitus associated with a vertigo, and sometimes Meniere's, I should say, is more of a medical treatment. You'd be seeing ENT for that. Sometimes treatments for that can help with tinnitus and vertigo as well. But generally, on the whole, for other conditions, no, there would be no effect.
So we are slightly past our time. I do want to remind you that there is another session in 2 weeks. It is Carmela Tartaglia, who is the co-director with me at the Canadian Concussion Center, and she is going to be presenting a talk entitled Concussion in Women, which is an extremely important talk because for reasons unknown, women are more sensitive to concussion. That is, they tend to concuss more easily than men. And we see that in sports and recreation, motor vehicle crashes. And the other reason is that women take longer to recover. And if anybody knows the reason why, please let me know, because I do not know why that is, but certainly amenable to research and further investigation. And now that this has become known, there is some research that is beginning to try to answer that question. So I would like to, on your behalf, thank Shaleen Sulway and Elizabeth Crawford for outstanding presentations tonight. Thank you to Christian Peterson for being so helpful in getting me going after somehow I was disconnected at the beginning. And we'll see you in 2 weeks. Bye.